we are discussing the report of the study which was done by NIMR. And although the report is on ICHF data, but I think it's going to provide us with a very valuable insights, especially as we are discussing how we can make sure that the remaining 80% of population is covered. So to unpack all these findings and reflect on practical implications, we are honored to have distinguished panel representing public sector, academia, private sector, and researchers. But before I start to invite the panelists, I want you to reflect on these very simple facts, which probably most of you knows. So I'm going to give you the facts about 4 countries, 2 from West Africa and 2 from East Africa, Ghana, Nigeria, Tanzania, and Rwanda. So starting with GDP, Ghana has GDP of around $80 billion US. Tanzania have 79 GDP billion US dollar. Nigeria has 3 times almost for all those, around 240 something. And Rwanda has GDP of 14 billion US dollar, which means Rwanda is probably a third of the other 2 countries. Again, looking at the population, Nigeria has 237 million people, Tanzania has 68 million people, Ghana has 35 million people, and Rwanda has around 14.5 million people. What else? Let's look at the insurance coverage. Rwanda has 90%, Ghana has around 60%, Tanzania around 15%, and Nigeria has only 5%. The funny fact is both these countries have public insurance schemes which started almost the same time. Tanzania, I think, after the law in 1999, NHIF started the operation somewhere around 2001. In Ghana, operation started in 2004. In Nigeria, which currently is called NHIA, but operation started 2005, and Rwanda started in 2001. However, we would like to reflect why this huge difference in insurance coverage in these 4 different countries. So to reflect in that, I would like to invite Kwasi Boahene, Director of Health System and Advocacy, PharmAccess Head Office in Amsterdam, just to share with us some important lessons for UHC in Africa. Kwasi, you are most welcome.
Thank you very much, Harry, for setting the context for this presentation. Can you see a slide in there? So I'm going to share with you some lessons that we've learned across various countries in Africa about health insurance. And of course, I want to emphasize that this session is important in the sense that, you know, the whole Tanzania Health Summit is about innovations, but if we don't have the money to pay for it, the discussions will just remain ideas. So talking about financing, whether in terms of investments or in terms of health insurance, is key. If I can have the next slide. So what we see, and I think Harry also said it, that across Africa only, can I have the mic? Because I can't see my slide. I can't see myself. Yeah. So across Africa, only 8% of the people is covered with insurance. And of course, the slide shows that Rwanda, Ghana, and Gabon have made good progress. you can go back, because, yes. So Ghana, Rwanda, and Gabon, they've made progress where obviously Rwanda have around 80% of the people covered. Ghana is around 60%, and Gabon is around 40%. And of course, if you come to East Africa, you know, Zanzibar as a state is not here, but I think within the past 3 years, Zanzibar has made good progress in terms of covering civil servants and their dependents. So there are some few lessons that we've learned that are important. And these lessons, they really don't have so much to do with implementation and, you know, analysis and all those things. They are pure facts that got to do with decision making. So if I can have the first slide. Yes. So one of the things that we've learned across the countries is that health insurance is a political choice and not a matter of wealth. You know, Ghana, Rwanda, and to an extent Zanzibar, they are not the richest countries in Africa. But if you look at it in terms of coverage, they've done really well. You know, prioritizing and making sure that, you know, they set aside public financing for insurance. The next one. And obviously, when we talk about health insurance, you know, the first point is, yeah, we don't have enough money to purchase drugs, to build hospitals and all those things. They are important, but I think the countries and the governments that have made the choice for insurance, they base it primarily on the issue of sovereignty, dignity. You know, how do we promote solidarity among the people? And for that reason, they actually go for insurance. Because, and I always say that, you know, solidarity is African. You know, until Europe came and, you know, talk about insurance, which is also a form of solidarity. But if you look at people helping each other, when you talk about insurance, that's basically what we are also talking about. Next one, please. And obviously, I don't know whether, you know, we are in difficult situations. Let's face it, that donor funding is being cut wherever you are, whether in Africa or in Europe or US, we've seen it. And the consequences are dramatic. But at the same time, what we have to realize is that donor aid cannot help guarantee solidarity in Africa. You know, the ownership is on African governments and individuals to make it work. You know, they can help us, donors can help us build capacity, and I think this morning we heard from the collaboration between D3 and the various ministries. They can help us catalyze innovation, but the extent to which we sustain solidarity, we sustain support to the most vulnerable groups within the populations, you cannot really depend on a donor. So let's also put things in perspective and, you know, stop moaning about donor aid and use that as opportunity to mobilize domestic resources. The next one. Obviously, when we are talking about insurance, it's quite tricky if you are in, whether you are in Tanzania or you are in Ghana, you know, and name the countries where 50% of the people are poor. And for that reason, whatever insurance product that you develop should be low cost. And you should be able to, you know, administer or implement it in the most efficient way. You know, previously it's been very difficult to do that, because then you have to marshal, you know, whole army of people to go around countryside. You have to set up administrative systems, sometimes paper-based, But technology has demonstrated that in spite of the poverty, we can still achieve scale. You know, if you look at East Africa, the way that mobile payments have transformed commerce and financial inclusion, there is no excuse that we cannot use the same technology to improve access to health. So the challenge actually is that if mobile technology has expanded access to finance to people who don't have bank accounts, who cannot even read their bank statements, if those people have been included in finance and are making transactions, and it will surprise you to know that when we talk about mobile payments, it constitutes about 10% of the GDP of Africa. If you look at US and Europe, it's just 2%. So you see that Africa is ahead in terms of mobile payments and the technology and mobile technology and all the benefits it offers. So we actually don't have any excuse to say that we cannot deliver low-cost insurance because we have to set up administrative system. You know, Ghana, where I come from, has really demonstrated that with technology, people don't even have to go to the office of the National Insurance Agency to register. You know, you can just do that within a minute or so, you have insurance. You know, they've also rolled out ID cards, which are digital, so all your information is there. If you don't like the services that have been provided, you can easily complain through your mobile phone. And we're not talking about a smartphone, right? We're talking about the normal feature phone. So we all have the possibilities to do well, and we should actually grasp it. I think this is the last slide, and then I will, you know, certainly participate in the panel discussion and take up any question that you have. Thank you very much.
Thank you very much, Kwasi. So, and now to hear about the findings from the study, please allow me to invite on the stage my first panelist, Principal Research Officer, Director of Research Information and Regulatory Affairs at National Institute of Medical Research. Please welcome Dr. Mary Maige.
Good morning. Thank you, Dr. Mara, and thank you to the previous presenter. I stand here to present to you. Sorry, I need my glasses. I don't know where I got the confidence. So as I have been introduced, my name is Dr. Mary Maige. I am a research scientist at NIMR, and my research work is mostly on non-communicable diseases, and I was honored to be part of this work that looked at evaluation of the implementation of the ICHF in Tanzania, and also describing the lessons that were learned from its implementation and how it can be leveraged towards universal health access. I would like to acknowledge the NIMR team that work tirelessly to analyze this data, who are here in this meeting, and also PharmAccess and PureOut for working with us on this. Next slide, please. So next slide. Yeah, so I just wanted to set the stage by putting this world map that puts us into context. So the red countries are the ones that have less than 50% coverage in health insurance. And you can see Tanzania, we're amongst them, and we've been informed that our coverage is around 15%. So my presentation layout, I'll talk about the background, why we did the work, what was the rationale for it, the methods, findings, and what are the key recommendations. So this work focused on analyzing data on improved community health fund to inform implementation of universal health insurance in realization of a universal health coverage in Tanzania. As you know, the country has already enacted the law to pave the way towards implementation and increasing coverage to insurance to its citizens. And this was a collaborative work between the National Institute for Medical Research, Pure Large, and PharmAccess. As we have been informed, the country continues to struggle with low health insurance coverage despite the ongoing financing reform, and we note that there has been marked improvement, but as of 2023, it was reported only 15% had coverage to health insurance. So next slide, please. So the main objectives of this study was to analyze the ICHF data to inform implementation of UHI in Tanzania. And we described the trends and characteristics of the enrollee, the members that enrolled into that scheme from 2019 to 2023. We also did the work to determine membership renewal rates, to identify factors that were associated with renewal and re-enrollment in the scheme, and to determine what kind of disease persons did the patient that visited the health facilities, what they had, and we also looked at the resource mobilization and utilization throughout the years. Next slide, please. So this was a cross-sectional analysis, and we looked at retrospective data from the ICHF Insurance Management Information System database that is hosted by Pure Large. And this, just to give a background, this database maintains comprehensive household and healthcare records for all ICHF beneficiaries, and key data elements that we could access included the household and demographic information, region, district, which villages, and the head of households, the principal members, and the dependents, the personal details, and what the relationship they had with the principal member, and also healthcare utilization data. Next slide, please. So I just present some of the key, just few findings from the analysis. And the first slide on findings that I'm presenting is the findings on enrollment and renewal. So in total, from 2019 to 2023, a total of 890,000 individuals were enrolled. And this enrollment was at peak in 2021, because they started in 2019. And then it dropped significantly in 2023 to less than 100,000, from 270, around 270,000. And the renewal rates, as you can see, we have the blue and the red line. So the blue line is the total number of members, but then the red ones is the new one. So it looked like every year the new members were more than the total, the numbers were almost close to each other. It meant that most of the time they were getting new people into the scheme, but they also had high dropout rates across the years. So the non-renewals were quite high, and that was quite significant. But then it was good news that as the years continued, the the number of, the percentage of people that renewed kept on increasing from 10% to around 30%. But then we know in the end this could have been the drop, and the non-renewal also could have been affected by the UHI, because that's when the discussions were ongoing. And I think a lot of the advocacy work and the efforts that were put in the beginning somehow did not continue. So probably that could also, that could explain it, but this is the picture that we saw in the data that we analyzed. And then in terms of the financial performance, so the total contributions, they rose from 2 billion in 2019 to 12 billion in 2021. So we saw that we could mobilize resources from this community health insurance fund, but then it declined in 2023 for reasons that I might have speculated earlier. And then the reimbursements also continue to rise because as they enrolled new members, people saw benefits and they started coming in, but then probably there could have been adverse selection because also the healthcare cost kept increasing to the extent that the contributions and the reimbursements actually in some cases outweighed the contributions. And Dar es Salaam contributed the most financially as is expected, but then also experienced quite a bit of deficits as one of the regions where expenditures were high. So there was also an increase, a notable increase in number of healthcare utilization over the years. I think as people got more aware of the scheme and what it can offer. But then also, health visits for non-communicable diseases slightly outnumbered the communicable, because we know non-communicable diseases, they have to go more often to the facilities, and the average was at least 1.17 visits. But then when we looked at the NCD visits with the assumption that an individual needs to go repeatedly to the facility, we didn't see a markedly higher number, so still there was a gap in healthcare utilization. But also we saw the financial challenges due to declining member contributions and also those intermittent financial deficits. But we also know NCDs, they tend to increase healthcare costs. So as we go towards planning for the universal health insurance, we need to also bear this in mind and make sure that we plan accordingly. Next slide, please. So we have a long list of recommendations, but I'll be very brief. So we need to increase the UHI enrollment and renewal equity through focused outreach. So we could see there was disparity in terms of age, gender, region, rural, urban. So when we go towards the rollout of UHI, we need to put all those into consideration to make sure that our rollout has an equity lens to it. But then we also need to leverage the digital possibilities that we have at the moment, so that we increase our reach even to those people that are in the rural population, but have also strategies for those that have been digitally excluded when we plan for our strategies to include and enroll new members. But we hope in the end we'll be able to reach all Tanzanians. We'll have policies that will enable us to make sure that every Tanzanian has access to health insurance. So the next recommendation is to make sure that we strengthen financial and enrollment mechanisms. We know that the people that we're going to reach that will not be able to fund themselves into the insurance scheme. So just to stress this, we know it's in the plan, but to make sure that during implementation, this is implemented as planned so that we don't exclude or leave anyone behind. And here we call for more pooled resources to complement being collected from the individual contributions. And then the other comment is really increase the financial risk. So it is recommended that we promote more household enrollment so that we diversify the risk and make sure that we all participate and it really becomes a universal insurance. And one of the final recommendations is to make sure that we integrate NCD into UHI. One of the challenges, this is from literature now, but we kind of saw in the analysis that we did, is that NCD packages were not really considered in the basic benefit packages, especially at the primary care level. So these community members, they had the insurance, but when they went to the facilities, some of the basic NCD services were not part of the packages. And as our data is showing us, there is more and more older individuals that were actually enrolling into the ICHF scheme, and we could deduce that most of these were due to NCDs, because our expectations was that families with more under 5 children, the households with under 5 children, will be the ones that will be enrolling more into the ICHF. But as the years went by, we saw the households with older individuals were the ones that were enrolling more compared to the others. So NCD is coming in there. So our basic benefit package needs to also consider that and make sure that we also have full pooling of funding to mitigate some of the financial challenges that will come in as a result of increased NCD burden. Next slide, please. So another recommendation is to make sure that we have a robust monitoring and evaluation and accountability framework. While analyzing this data, we had challenges because we could not directly link the contributions and the expenditures. So, so some of it we just did proxy analysis. So the contribution data was not linked to the service data and not linked to the outcome data. And I think while we are building systems for UHI, we need to make sure that we have a robust system that can help us analyze and make useful recommendations from it. And to make sure that we have a transparent provider payment systems and secured data system to support that. And as we know, we have created an enabling legal and regulatory environment, and we need to continue improving that to make sure that it takes us to the universal health insurance and universal health access to all. Next slide, please. Thank you for listening, and I would like to acknowledge again all the team members that worked with us on this project and yourself for attending this session. Thank you.
Thank you very much, Dr. Mary. If you can join me here on the stage. And now to join Dr. Maige on the stage, please allow me to introduce 3 other panelists. First one, from Kampala International University, Senior Lecturer and Researcher in Health Economics. Please welcome Dr. Derek Chitama. Please allow me also to welcome CEO of Jubilee Health Insurance, also medical doctor by background, Dr. Harold Adamson. And last, but definitely not least, a senior officer and currently regional manager at Ilala Regional Office for NHIF, Dr. Malaba. Karibuni. Okay, so thanks, Mary, for the presentation. And I think the panelists, you were listening and follow the presentation from Mary. So to start our discussion, I'll start with Dr. Malaba. We understand that with the UHI Act, NHIF now has we have responsibility to provide cover for everyone, including the informal sector, which previously was not your main mandate. But the report, as you have seen, shows us that with informal sector, one of the key challenges is enrollment, and even bigger challenge is re-enrollment of the informal sector. So can you tell us how NHIF is prepared for this challenge to ensure that we have the 80% who most of them are informal sector covered into health insurance?
Thank you so much. As far as NHIF is concerned, pertaining to the enrollment strategies, NHIF has already engaged of insurance service distributors, partners, agents like banks. We have started negotiations with NMB, NBC, banks, and already signed the contracts with other agents like Vodacom, of which they are going to facilitate the process of registrations. We also had already completed signing contracts with some other insurance agency, Wakala Wabima, and they are already working with us to some other centers. Another strategy is the fund have started the process with engagement with the community health workers, whereby they will facilitate to ensure that every communities will reach to the members. There is also internally we have instituted the individual targets to all staff, of which all staff they are being obliged to ensure that they meet their KPIs. We have instituted the online service whereby NHF beneficiaries and the citizens currently they do not need necessarily to come to our office. They can register via the online portal at their workplace or whether they are at home. Also, the fund had already integrated with some other government institutions and agencies like NIDA, whereby currently NHIF we do not need to produce ID, so they can just use the national identification to ensure they access medical services.
Thank you very much. And I think the last point you just mentioned, that's very important, because I think one of the challenges is normally the identification of the members. And speaking of that, we know that informal sector also includes the group of people who cannot afford to pay, which are estimated to be 26% of Tanzanians. And we understand that government already allocates some funds to make sure that these people also are covered through the subsidized premium. So how is NHIF prepared to identify these people who are the poorest of the poor to make sure that they are also covered in the scheme?
Prepared to identify and enroll indigents, actually, as per UHI regulations, the identification of the role is the role of the MOH, TASAF, and the President's office. However, the fund will only receive the names and their premiums. And thereafter, we do prepare their identifications to ensure that all the members, they receive medical services. And the fund is already on verge to ensure that all the identified members, they receive their IDs so that they can process their medical services.
Thank you very much. I'll come back to you, but now let's ask my friend, Dr. Adamson. I understand that you have been active for more than 15 years in private health insurance. With this UHI Act, which I think you also has the role to play, how are you prepared in covering the informal sector, especially of this basic benefit package, which probably has a lower premium than your normal packages? So how are you prepared also to get involved in this?
Okay, thank you. There are a couple of ways as a company we have been involved by the government also during the preparation of the regulation itself and the formation, but as well as at this particular time as a company, we have managed to create a couple of products to cater for that particular group. So we have tried to diversify, not focus only on the corporate accounts, but rather on the retail space as well. These are individuals, and with collaboration with the NHIF, if they will be ready at that particular time, and I will advise that collaboration needs to be there. We really need to see how, through private insurance company, they can easily come up with micro insurance products, and these particular products also can support the number of common citizens. But also, the basic cover which have been provided by UHI, we can also come on top of it, just on a top up, especially for the services which are not supported by UHI, from the presentation of Dr. Mary as well. So there are a couple of lines which are not supported by UHI. She just mentioned the NCDs, but there are also other areas, they're like specialized areas, fast tracking on the service perspective when the person goes to the hospital. Private insurance can easily come into a space and cover that particular space in the future.
Thanks. Dr. Malaba, you heard from Dr. Adamson. What's your opinion? Do you see any opportunity for PPP between NHIF and private?
Sure, we do. We do see, and NHIF currently has certified more than 10,000 facilities, and these facilities encompasses from public facilities, private, and those owned are the faith-based. So it shows that the NHIF have been working with the private sector to ensure that they deliver quality health care to the community. So even during the time of UHI implementation, at the same time, so we'll be working closely with different partners, service providers, and other agencies. So when we talk of members, we have a number of categories. We do have members under public, but still we do have private. Currently we are serving corporate customers of whom they are enjoying services and supplementary services and a comprehensive scheme. So we do have all the groups. We do have even those small groups of which they have special packages for their services.
And in terms of insurance partnership, like NHIF with private insurance companies, do you have any which you can share, or do you think in the future you can have any kind of partnership there?
Of course, we are on verge for it. For instance, as you could see from the UHI Act and the regulations, there will be a special insurance for travelers. So the fund will be working closely with the domestic and international insurance to ensure that there is reinsurance, and for those who are within, they also get covered.
Thank you. Maybe now we move to Derek. Derek, I understand you've done a lot of research in the area of health insurance. Can you share any lessons from other African markets, developing countries, where private insurance has successfully supported the national rollout of the national insurance scheme?
Yeah, thank you. I think we have quite a number of success stories from different countries where private institutions have supported national scheme to advance their coverage. I think I would start with Nigeria. Nigeria is one of the examples where they are using what we call health maintenance organization to manage enrollment, but also to manage payment. That means now they're using this health maintenance organization to do awareness and get people enrolled on the scheme, especially for the informal sector, which I think we are targeting here. They also manage contract and process claim. So again, here you see that in Nigeria they have managed to split the provision and purchasing of services. And it has helped to have a rapid admin of the scale-up of the insurance for the informal sector. Though there are payment delays, but Tanzania, we can learn from that and and avoid those payment delays. Another example is India, where they are using private insurer as implementing agencies. Here is the government float tender to private, where they can they are commissioned to do again enrollment and impanel the provider and pay claim to for the defined packages. So what was the advantage of this in India? They were able to reach many poor using this approach. And then another example is Colombia, where they have private institution or so with this approach, multiple insurers compete to deliver one national policies and one national benefit plan. And it has worked because it has incentivized the efficiency within the service provision. So how we can make it work here in Tanzania? For example, NHIF can work with private insurance in making sure that the UHI Act is being implemented, where they can create risk equalization and through TILA, Tanzania Health Insurance Regulatory Agents, and leave the enrollment open. Then the last example, I think, I would go for South Korea, where they've got both public pool and private pool. What the mechanism here? They have got a single purchaser contract where private system, private providers are commissioned to deliver services through contracts, and there's tight utilization and audit of the service provision. And so the bottom line here is, I would say maybe is for Tanzania to keep pulling and benefit package, the basic benefit package, stewardship through public, and use private insurance for administering the scale up of the enrollment. Thank you.
Thank you very much, Derek. I think you gave that example of more in Nigeria. I'm not sure someone from Kenya here, because I know the new act, UHC Act in Kenya, also put a private company to do the claims adjudication. So I think that's one of the examples where private can take part. So Dr. Adamson, I know private, in most cases you are advanced when it's come to the use of the digital technology. So what role do you think digital technology and the use of the data, and especially now speaking of AI, it can play to address these challenges which were identified in this presentation from Dr. Mary?
Thank you. Thank you, Dr. Maro. Before I respond to that, maybe just to echo what the doctor said here, I think we need to move from operational collaboration, and we need to focus on the technical and the strategic collaboration more, which can also help our people, especially in risk management. You know, as private insurance companies, we don't own the risk 100%. We usually push our risk as well to the reinsurance companies. By putting those particular layers, they help us to have a sustainable companies in a long run. So in the same manner, if we have a strategic collaboration in risk pool management, it will help us to service well our common wananchi as well as the country at the end of the day. Coming back to your question in terms of technology, I think technology has helped us very much in terms of disseminating information. Just a simple way, communication, awareness. The focus now is more on the youth, but as well as the informal workers. So by using the same technology, you can tailor-make type of information which you want to disseminate to people. You cannot send the same information for a person who is at Kazuramimba, the same information the same person is in Peramio in Ruvuma. So at times you need to customize the certain information. By using technology, you can easily do that and discuss with those particular people in terms of what kind of a message you want to give it to them when it comes to the medical insurance. Technology as well, it can help us, and it has been helping us to identify the poor at the end of the day. By using data analytics and getting the proper information of the utilization of people in terms of mobile money usage, you can easily tell if this person is capable to do the payment for this particular policy or not. Then you can easily advise the member. Even if you cannot pay for J-Care premium, but you can also pay for J-Care, you know, a different one, so that he can sustain his life as well as he can continue to be on cover. So those are the day-to-day activities we are facing, but through the information which we are keeping, they help us. So as a company, we are a regional company. So as a company, 2021, directors made decision intentionally to invest more than $20 million in the technology. And one of the areas which we have seen results is on the fraud detection and controls. By using technology now, we can see the pattern of claims which are coming from the provider's level, and we can tell by using this particular pattern, there's a problem here, and the claims team can easily go and look at it and say, okay, now what the kind of discussion which we need. So by using AI, we have a proper system which is called QRSL. Now we are saving more than 100 million per month. I'm not wrong. 100 million per month, which we used to pay before August 2024. Now we cannot pay because some of them are duplicate. We used to miss them. Some of them, they were overbilling. If you add up an average of 100 million. So it was an initial investment, but now we are seeing the results out of it. We are receiving the claim on time, but also we are paying on time. We are detecting where the gaps are. The other area is the provider payment. Providers, at times, they can be reluctant to say, okay, now I cannot put proper system, especially in the rural areas. But by submitting your claims online, it helps a lot the turnaround time of the insurance company to do particular payments to your side. But for us as an insurance company as well, they help, we collect the information, which helps us in our today's operations in terms of policy design. By the number of information which we have, we can create a policy which can support a member in Marangu, Kilimanjaro. Specific, because there's no need of having a product which can be paid the same amount a person at Samora paid the same amount as the resides in Pemba. We understand that the quality of life is different, the economic status of these people probably different, but also the cost of treatment in Pemba and in Dar es Salaam, they're totally different. Why are you pricing the same? So by using the technology as well, you can do the data analytics and get the proper policy structure to support the common mwananchi. Thank you.
Thank you very much. I have a lot of questions to ask my panelists here, but I don't want it to be my session because I know there are a lot of people who has years of experience in this. So if Ashas, if you are around, Ashas, if you can, yeah, so anyone who has question or contribution, but before I allow that, Kwasi, you are still here, okay. I understand that you are highly involved in discussions around financing UHI in Ghana, and you are here now so we can get your experience on that. Can you tell us what is the most important insight that you got out of your involvement for financing UHI in Ghana? Please.
Thank you very much, Harry. So, Ghana, we started in 2001 because the opposition, and this history is important. So at that time, there was a change of government, and the opposition has been in opposition for like 19 years. So they had to do something that will let them gain power. And I don't know who advised them that insurance is something that can help because, you know, as you know, in most African countries, when we talk about improvement, we talk about physical infrastructure. You know, there's a nice hospital, everybody can see it and, you know, feel happy about it. When you talk about insurance, what do you see? Your card in your pocket? You know, who cares? But whatever reason, they said that insurance will help them. And they will pay, that's also an important thing. They said that the government will pay 70% of the cost. And you know what? The IMF and the World Bank, they told them that they cannot do it. They will go bankrupt. Because, you know, and they have all these kind of terms. They have limited fiscal space, meaning that they cannot mobilize enough taxes. And then the government said, we said we will do it. So, you know, whether, you know, forget about all this analysis. And they did it. And so just telling you that if you don't want to do something, you can jump on any excuse and deny yourself the power of action. So but what they did is that they increased VAT. They knew that it's difficult to get more from income tax. So they increased the VAT by 2.5% and made sure that that VAT went into financing health insurance. The World Bank and the IMF, they come with all this analysis because they are also not looking at the waste in the system. And the CEO of Jubilee Insurance made that point, that, you know, there's a lot of waste that now, you know, they save like 100 million shillings per month. If they hadn't introduced technology, that money would just go waste. So by looking at the waste that they had, you know, all the politicians in Ghana at that time, they fall ill, they go abroad. You send them money outside of the country. Why can't you use that to strengthen your own health system? Right? And COVID showed us that when you are ill, it's better to stay in your own country than go abroad. Thank you.
Thank you very much, Kwazi. Okay, so now, yes, the gentleman behind there, yes, from NHIF.
Thank you very much. My name is Abubakar Ndwata from NHIF. I'm coming from the Actuarial Research and Risk Management Desk. And given the importance of this topic today, NHIF is well represented here, and I would like to introduce a few colleagues of mine, starting with Dr. Guamaka from HQ. We have Dr. Mame from Temeke office, and of course we have also Dr. Malaba. We have made quite a very good contribution to the panel. And Dr. Godluck from Mwanza. Could you please stand up from Dr. Godluck? I wanted to contribute a little one or two things, and the preparation of NHIF towards the implementation of UHI. And just a few questions to echo what Dr. Malaba said in terms of identification and the rest, the financing part of it, etc. And rest assured, I have a little bit of an experience from TIRA. I stayed at TIRA for quite some time, so I know a few clauses in the Act, and etc. So we maybe to start with the identification part of it. We, as you know, traditionally NHIF we've been dealing with the publicly employed people. We were that much skewed, but we have gone to the private sector where we introduced private sector bundles. You know, we have the Ngorongoro, we have the, of course, different health insurance bundles. But now we need to see how to cover the 26.4% of the Tanzanians who are food poor people. Of course, it's quite difficult to mention in the first place. But what we are doing, we are working together with TASAF, and of course the work has started to try to look at those people who really need government financing from that part. And of course we have a package called, what is it, Faraja? The Faraja insurance bundle to cover these people. And in terms of technology, the fund has gone to, I think, very far. We are integrating AI into our systems. And we are starting with in the claims part. That because it will be a lot of, it's not a lot, it will be a bit higher number of applications sent to NHF for reimbursement and for payment. So we are working with the experts to try to integrate AI into our claims management systems. And of course, the project has started, and this is how we want to do it. But I want to echo the first presenter on the coverage. I think we have to agree, and I totally agree, that coverage is not about the level of GDP or anything else. I think it's a political will. That one I really, really agree. And of course, Tanzania is at a critical moment, and as we know that on the 29th of October, we're going to elect I think, the president of the country. And you know, one of the contestants has promised to deliver UHI in the first 100 days. And of course, it has come down to 10 days, Mr. Moderator, if you know that. I think the very last speech was now we are working towards the implementation of the UHI, I think a pilot UHI within 10 days. So I think the KPIs has changed, and of course we are really preparing into that. Now, in terms of doing things happening, we have identified about 5,400 providers, and we are working on the financing method. And I think the PPP question, it was quite a very valid question. What we want to do is to look at the capitation payment method. So by that way, we'll be advancing some sort of capital to health services providers. So I think we'll look at that and see if we can advance, we can look at some other needs from other providers so that the program can be successful. So I think my team is here. If there's anything which is important to mention, I think they can compliment on my comments. And thank you very much.
Thank you very much.
Yeah, thank you. Sure. My name is Dr. Gibson Kagaruki. I'm from the National Institute for Medical Research in Tanzania. Mine is a question maybe to the policymakers who are in front of us. I have done some couple of research, including the one which has been presented by Dr. Mary regarding the universal health coverage, and the other from the community. The big problem regarding enrollment and re-enrollment is on quality of service the clients they receive from the point of care. So people, they are not willing to re-enroll because when they go to the facility, they don't get the quality of service. And the big problem for that, it's on the risk pooling principle. It's not applied in our country. People, they do join to the scheme when they are sick. If they are not sick, some they tend even to claim that I contributed, but I didn't get sick, so I need my premium contribution. Is it possible maybe to capitalize on the system which has been used by TANESCO, by government, to ensure the coverage of electricity in the rural through REA programs, where there's indirect deduction of the contribution, instead of telling the village people to contribute so that they can get the power, then the money is deducted from the utilities. Like when you you recharge the power, there is some deduction for the layer program. When you buy fuel, there's some deduction.
Okay.
I did
Thank you, Dr.
So just to cut short.
The point is clear now. If we can take
Just
to the
to
next.
give an example, I did the analysis when I found that in Tanzania, 2 years ago, we were using almost 4 billion liters. By deducting only 100 per liter, Tanzania can rise at least 400 billion, which can go direct to cover the universal health coverage. Now, my concern is that on capitalizing on the layer system. Thank you.
Thank you. Can I proceed? So I'm Dr. Alex Mputa from Thaminio High. My question is on a practical side, especially for providers. So what will be the financing mechanism or the cycle? Who collects? Will there be a one pool where all funds are collected and then the providers have to request for those funds to go to their facility? Or is it going to be a facility-based financing to give them capability of having access to medicines and other services?
Thank you. Dr. Mbatia.
Thank you very much, PharmAccess, for this session and for the presenters also. I have a question, I'm not an expert in this, on the information from NIMR is really helpful, you know, the M&E that needs to be strengthened. I'm actually wondering how much or to what extent have we or are we planning to incorporate this to the current operational systems of NHIF so that we really can get to know the loopholes early enough and not wait until, you know, the CAG, for example, find out there has been a lot of losses which could have been used to cover the services that they're intended to. So to what extent are we using that data? Thank you.
Thank you. Yes, Eric, and then there is a gentleman behind you.
Thank you. My name is Darison Andrew, District Medical Officer from Sengrema. My question goes to Dr. Maria Maige. First, I appreciate the presentation of the study we did. Now, this is based on the experience in health insurance. We had a challenge on the way. My case study is on SHF. When the client service has been serviced to the point that the cost of the service is bigger than the payment from ICHF in the means of remuneration. This has been the barrier to most of the clients raising to complain. Now it is going to NHIF. What was your position or the observation you came up with that could be leading us when we go to universal insurance, we'd be escaping this challenge? But then the other thing is something to do with this economy of scale in health insurance. The experience shows there are some of the barriers on the way, something to do with the administrative complexity, regulation challenges, are the hinders of insurance. What did you come with in the course of observations? Thank you.
Thank you, Dr. Andrew. I'll come with a second round, but so to respond to those questions, and I also want to add a question related a bit of what Dr. Kaigaruki mentioned. I understand that, of course, already the new tax law allow deduction from the fuel to finance UHI, especially as a subsidy. But my question is on the quality side, because I think he put it very right that re-enrollment is mostly affected by poor quality of services. And I understand that's the role of the providers, owner of the providers. But I know that there are some ways insurers, you can also influence quality of service provided based on the payment mechanism you are using and other things. I would like to ask Adamson and Dr. Malaba, how do you think you can also support Ministry of Health to make sure that provider you are contracting improve quality of service they provide. So if you can respond, and then if there's anything else from the audience you want to respond, you can also add.
Okay. So when it comes to quality, there are a couple of areas which we are working on. And I've seen my head of quality assurance here. So we have a quality assurance department within the company. And what we usually do is do quality assessment on a regular basis to the providers. We do trainings to make sure that they are there to national and international standards when it comes to treatment. And at times we motivate them, especially those ones in the far areas of our country as well, in terms of the timings of the payment as well. And these have shown an increase also in the collaboration between us and the service which our clients are getting from those particular service. But also we have introduced some of the digital tools to support them on the day-to-day activities. Some of the tools we are giving them, the computers and so forth, to support their work in those particular areas. We have supported some of the facilities in the rural areas so that at least they can be able to identify our members, but as well as to provide appropriate services to those particular members. Maybe I'll leave an opportunity for my colleagues as well to respond on that.
Thank you so much. In terms of quality, the fund had a directorate of medical and technical services. The directorate have a number of functions, and one of the functions is to ensure that advocacy, trainings, and supportive supervisions is conducted to service providers. We do visit facilities on a monthly basis and sometimes on a quarterly basis, depending on the issues that raise from service providers. However, we do have a system in place for collaborations and the communications with service providers. Internally, we do have a robust system. This system is supported to ensure that services offered to our beneficiaries align with the standard treatment guidelines. And if there is an issue, we do communicate and discuss. And this system has also helped the service providers in providing the services as per the guidelines. But also I received one of the comments from this was the challenges of ISHF as they are trying to focus as we are going for NHIF. What will it be? Of course, if you try to make the comparison between ISHF and NHIF, these are two separate funds. And the mode of operancy for the ISHF and NHIF is quite different. NHIF is either health insurance, but ISHF, the mode of operations, it was quite not similar as to NHIF. NHIF have been experiencing for the past 25 years, and we have a competitive advantage in social health insurance, and we have confidence that we can work without any problems. When we talk of premiums for the ISHF, it was not realistic compared to the services. That's why you could see some complaint that even from service providers, what they received or reimbursed was quite lower compared to the services offered. But for NHIF, we do conduct costing. And costing studies provides the actual cost for the services. So we have itemized the services. For each services offered to beneficiaries is always almost the same to the market value. So in so doing, it provides even the attractiveness to the service providers. So we are ready, and we are quite sure that it won't provide the challenges to our service providers. And we will be applying two payment models. We have our fee-for-service, which have been there from primary to tertiary facilities. But for primary, we are going to deploy another payment mechanism called the capitation model. And that will allow service provider to enjoy some other advantages like earlier payments. Some will be paid maybe in advance, sometimes within 2 or 3 months, or maybe immediately after payment, claim submission. So all of those are some of the strategies to ensure that service providers, they can continue offering services without any challenges.
Thank you very much. Derek, in one of the comment which was made, I think he was trying to refer how REA is funded. So do you have any lessons from other sub-Saharan African countries which can inform Tanzania on how we can subsidize payments for the poor? If you can share any examples.
Yeah, thank you. I think we can learn from other countries how they have been subsidizing payment for the premium, especially for the poor. Though not exact as the REA has been presented, but maybe the principle are the same. We have examples from Colombia where they are using earmarked taxes to pay for the poor. And here for the poor again, they have gone to the extent of categorizing the poor. We don't give just a blank package for all of them. So they're using what we call social registry, like what we're having at TASAF. But again, they are categorizing poor to 3 categories, which are the very poor, maybe moderate, and a little bit better. And all these, they are given different subsidized. For example, very poor, maybe they are being subsidized 100%, maybe the moderate one, they are being partially subsidized, and then maybe the better one are allowed to pay. So, but again, this money from the earmark tax is ring-fenced. It's solely ring-fenced for payment of service of the poor. And another example could be one from, I think, Thailand, where they're also using general tax to subsidize, to subsidize the premium for the vulnerable group. So what I can say, if we are going for the REA, but the issue is we need to ring-fence this fund and being directed straightforward to the payment of the subsidies. Otherwise, if it's not ring-fenced, it can be reallocated, and then we have.
Thank you. Dr. Mary, I think there's one question for you there, but in addition to that, because I know also you looked at non-communicable diseases and its impact in UHI. Can you also please share some findings and your opinion in relation to inclusion of NCD management in this basic benefit package?
Thank you. Thank you, Dr. Harry, for that question, and thank you, the question from the audience. So the question from the audience was asking on reimbursements versus the service provided and the misalignment they experience. I think partly that has been covered by Dr. Malaba's answer, but giving experience from what we've seen in the analysis that we did, although I made that caution that there was no direct link of the amount that was spent vis-a-vis the expenditures, but we could deduce from the additional analysis that we did, looking at the number of visits that were made and when the visits for NCDs occurred. So we saw that over the years, the fund accumulated more patients with NCDs in terms of the visits kept increasing, and they had more visits. So that is one, that NCD can impact on the healthcare finances, because then you require more visits. If I ask doctors, NCD doctors sit in the clinics, we need to see our patients maybe every month or every quarter. But if somebody has an infectious disease, probably you'll see them maybe once in 10 years. So, so that by default increases healthcare utilization. The other is we don't enforce protocol-based care, because for NCDs, it's not about getting a cure. So these patients come to the facilities repeatedly. And there's so many drugs that you can use to treat a similar condition. For hypertension, you have a 50 shillings drug. You could have a 5,000 per tablet drug, so it's your choice. But then how do you make sure that only the person, regardless of the income that they have, that requires that 5,000 tablets, gets access to that 5,000 tablets, but not that the provider can just decide and say, the way I look at Dr. Mary Maige, I think they should get the 5,000 tablet, and this other person gets a 50 shillings. So we need to have systems to be able to make sure that we look at cost-benefit cost-benefit ratios of the different treatment options that we have in country. I know we use research from publications and p-values from other countries. We are so diverse, both genetically, both in terms of the etiology of these various diseases. So if we take results of studies that have been done elsewhere, and they tell us that this 5,000 tablet is the one that works better, and we have not looked at our data to see whether we're getting the same response with the additional resources that we're putting, I believe that is what our colleague from Jubilee was talking about, efficient use of resources. So how do we build our essential medicine list, our essential services? How do we build them? Are they backed by research? Do we do our own cost-benefit analysis? So that is where we can actually efficiently use resources. The other is quality of care. Because if the data that we have, we see that we have many patients that are not meeting treatment targets. And if you're not meeting treatment targets with your patients, it means that you're injecting the resources, but you're not getting the outcomes that you deserve. Because most of these patients, if they're not treated well, they will end up with multiple complications and hence increasing your healthcare costs. So is this really what we want? Because we want people to be able to access secondary preventive services and primary preventive services and primordial preventive services. And I think the bigger picture that we need to look at is how the resources that we're mobilizing from the health insurance also goes into servicing the public health interventions, because what is happening at the moment, if I have a health facility, I have to make my patient sicker and sicker for me to be able to make profit from any of it. So it does not, the current financing mechanism does not influence me to focus on prevention. If I see a patient and don't prescribe multiple drugs and just put there the consultation, I don't think our insurance will reimburse that. Will tell, oh, what does this patient come to do at the facility? But maybe you took 2 hours educating these patients about maybe their diet, their weight control, their management. But if I don't prescribe there a long list of patients, that visit is not taken seriously. So how do we then balance us creating more and more health problems, quantifying diseases and quantifying resources that goes to the to the facilities? Can we have a financing mechanism that promotes more public health and preventive services rather than treating conditions and not really facilitating prevention from primordial, primary and secondary that's my short version of the answer, and apologies for that. Thank you.
Thank you very much. So how can we get more for the less? Okay, so I have 10 minutes, so if I can take 2 questions. If you are brief enough, we'll have 3. So yes, from Eric, and then the lady behind, and then.
Thank you. I like to follow up exactly on what Mary just said. How can we ensure that prevention becomes part and parcel of an insurance policy in practice? And I'll give you 2 examples. One we will discuss tomorrow is the health screening of adolescents in order to prevent a lot of diseases. Now I would like to to focus and ask you the elderly. And I take myself as an example. If you are in the age range 75, 85, and you are relatively healthy, then one of the reasons, there are many reasons, but one of the reasons is that you do an annual health checkup. And you screen yourself what could be a problem after so many years. That is not covered. It may be covered because I have a private insurance, but the NHIF, the ICHF do not cover any kind of preventive health care. While by doing so, I postpone a lot of cost to you in 5, 10, or 15 years. So it is a cost, in my view, a cost-effective measurement for an insurance company to cover the elderly that will get their cancers, their NCDs eventually by having annual health checkups, screenings in order to prevent that and take measures to prevent that. I didn't hear anything about that from this audience, and I wonder why not. Thank you.
Thank you. Matiko?
Thank you so much for a very great presentation. Yes? Yeah, thank you so much, panelists, for very good presentations. Mine will go straight with the improvement that we are seeing in the digital health systems, including the telehealth, telemedicines, and now they've been integrating even into these public digital systems. So how prepared are the insurance in terms of policies, guidelines, and some of the incentives to support providers who really assist their peers, especially through the teleconsultations or even on the case, virtual support on the case management. Thank you.
Thank you. And last was from the lady here.
Thank you. One question to NHIF. I have seen you have talked a lot about collaboration, but we have had and we are almost seeing every day there's no good relationship between NHIF and private hospitals. And we know that these private hospitals, they provide good and quality services. This is what the community believe. Now, how are you making sure that these quarrels between you and the private hospitals are settled so that the community and other people should benefit from the services? Another question to the community insurance. We have seen there's a problem in strengthening, but also when you visit those hospitals, especially the health facilities in the rural areas, there's a problem that funds which are supposed to be brought by you, they come very late. And therefore, these people, when they go there for services, they don't get services. And therefore, they are also even told this insurance you have is not working. We opt for you to pay by cash or join another insurance. Now, as we have seen the data you have shown, it shows. So how are you helping that to improve?
Yeah, okay. So mwisho la upendeleo pale nyuma. Yes.
Thank you. Thank you. Okay. Elizabeth Shai from National Institute for Medical Research. Just connecting to what Dr. Maige said in the previous audience, that health is a special good. I just want to insist on that, which means we have to foster ill prevention or ill care seeking. The challenge with insurance is that you have categorized the services as per level. These services are hospital level, these are for health center level, and these are for dispensary level. And we know that health centers and dispensaries are closer to the people. And again, we have lots of doctors and specialists down there, even to the private facilities. So you can find a dispensary having a specialist. But because we have claimed that the dispensary has lower cadre, the health center and the like, you find the important services are not available at those levels. So when they go there, they're told, okay, we cannot prescribe this medicine because it is not available. It is not, will not be reimbursed by the National Health Insurance. So at some point, these patients are referred to the Harlem, and they don't go for referrals because of distance and affordability in terms of transport. So what happens, they end up going to the pharmacies several times, and the condition becomes severe. So at the time they come to initiate the referrals is already critical, which means more cost to the health insurance. And we are currently facing the issue of AMR, antimicrobial resistance, because of this incomplete dosage or sometimes...
Thank you very much. I think the question is clear.
Yes. So I just want to know can't we do some kind of analysis of the levels and the capacity they have so that we can allow some services to be available, not because of the level, but because of the human resource capacity and diagnostic capacity.
Thank you very much. So if you can respond those questions, I think there is an issue of prevention, issue of the supporting digital, including telemedicine, and yeah.
Thank you so much. I will respond some of the questions that have been posed. Pertaining to prevention, it is true that prevention is better than treatment when you talk of the cost. And the fund currently, one of the challenges we are facing is increased cost for NCD. NCD is a burden, and actually the fund, it's almost 50% plus we are spending on NCD. So we understand. So the matter of prevention, it's a multi-sectoral, so it does not only involve NHIF, and it has been taken on board through the Ministry's office, and is currently on some processes to be implemented countrywide, so that NHIF will partner with some other stakeholders to ensure that that is being realized. However, the same services we are offering currently to corporate customers, it's already there, because when we talk of annual health checkup or screening, it's a assured cost, because you have to set a budget for it for each individual to undergo. Let's say taking maybe 100,000 per annum, maybe 200,000. So this should be budgeted for. And if it's not budgeted, automatically you cannot undergo that thing. So previously we could not manage for all members under standard scheme to benefit for the health checkup. But going forward, that is one of the strategies will be implemented by the fund. Pertaining to digital, improvement in digital health, NHIF have done very tremendous improvements in digital. Currently, we have a full system from entry at the healthcare facilities to exit. Our beneficiaries currently are enjoying biometric verifications, even facial identifications. For patients attending services like dialysis and the cancer treatments, they all use the fingerprint for accessing medical services. So all of these are some of the supportive mechanisms to ensure that services are issued on time, but still we reimburse service providers on time. So the matter of collaborations, of course, it has been pointed that there is maybe the collaborations between the private sector and the public sector, or private sector, especially the private facilities and NHIF, is not good. But maybe let me put it clear. In Tanzania, for most of private facilities, it's almost 70 to 80% of their revenue come from NHIF. And actually, some of them, it goes even to 95% of their revenue come from NHIF. So if that is the case, you can imagine how possible could you manage to work without a mutual understanding, without a mutual agreement with the two partners. Automatically, it will be a riot, or could be maybe something else. So I can assure you that we have good collaborations, we have mutual understanding with the service providers. It could be maybe an isolated case to one facility, but holistically, we're working together with a number of service providers. In Dar es Salaam particularly, it's almost 80% of service providers, they are private, not even public in Dar es Salaam. So you could imagine the situation could be if we could not have a good relationship. We do have, and we do collaborate in a different factors. Thank you.
Maybe it's a last chance. So maybe 1 minute I will use to just put a comment. To spearhead the UHI, I think we have to be intentional. We need to have what is called tax incentivization to our, even the private health insurance companies. At the moment, NHIF is under TIRA, Tanzania Insurance Regulatory Authority. They're engaging, I'm not a speaker of NHIF, but they're engaging agents and brokers to push for their business. When you work with brokers, when they raise an invoice to pay them commission, you have to pay with a VAT as well. That one is eating from the pocket. And now we really need to remove that tax part to make sure that at least the funds we are receiving from for the UHI can easily go for the payment of a hospital and so forth. The second part is prices which are coming from the providers level. If a person, a common wananchi, can go to Jubilee and buy Kitita or go to NHIF and buy Kitita, at the end of the day, he goes to a certain hospital, but the price in that hospital for NHIF Kitita is different compared to Jubilee Kitita, then it will not make sense anymore. I think it's a right time now we come to an agreement and discuss with providers and agree these prices needs to be the same for NHIF and for private insurance company. It will help our common wananchi. Thank you.
Thank you very much. Thanks to all participants. Just for you to know that we are blessed to have directors from the directorates which are dealing with health financing and health insurance from the Ministry of Health, Mainland and Zanzibar. We have Mkurugenzi Lusajo sitting there and Mkurugenzi Abdulatifu sitting there. So for sure what we have discussed here is going to be taken by them and see how it can be implemented in our UHC implementation. So thank you very much for being here. Thanks to the panelists. Sorry? Okay, one word from...
Yeah, thank you very much. I wanted to comment on two things. From the floor, someone mentioned about the public health. I think I want to echo what my colleague said here. They are going for two payment mechanisms. One is capitation. From my understanding, capitation always promote public health. So I'm not sure if they are going for the real capitation or the modified capitation, but if it's the real capitation, it incentivizes the implementation of public health. But also want to comment another thing on if we want to go for universal health insurance, we will need to sacrifice some of the things. We cannot go as it is. We need not to overpromise. At the moment, I think it's taken politically, but if we overpromise, then we will fail to show or to implement what we've overpromised. So we can go for a limited benefit package while focusing on the increasing the coverage. Thank you.
Thank you for ensuring equity. Asante. So mine is really talking about public health and public health and public health. So the vision for public health, I know we've been talking about screening individual patients, but I think we need to talk about the resources that are raised from UHI going towards finding disease prevention programs, going towards funding research in the country. We know we are not getting resources as we used to do. So we need to look at health in totality. What percentage of NHIF, I'm sorry to put you on the spot, but I'm talking about the entire UHI. How much, what proportion of that goes to funding those safe water, funding environmental issues, funding, those services. So not really screening patients, but how much of it goes to health education. Those departments that are overseeing public health, where are they going to be getting the resources? We want the resources to come from the implementation of UHI. So that's the last remark I wanted to make. Thank you. That was something.
Thank you very much, and apology for the next session for taking you 10 minutes.
Hello. Good afternoon. We are about to start the next session about the Pathfinder.
Sherita.
Hello. Good afternoon, everyone. Okay, we're about to start our session about Pathfinder. So, you are most welcome in the hall. From the back benches, you must occupy these front seats so as to have a good appearance of the hall. You are most welcome for the session.
Hello, good afternoon. Good afternoon, good afternoon. Karibuni sana. Please get seated. Nani, dada. Naenda tu straight. So kama mnasema the next session sijui nini ya Pathfinder sijui nini. Mlishasema? Okay. So welcome everyone. Naomba tukae. Dr. Eric, Prudence, karibuni. Karibuni tukae please. Thank you. So, Thank you. Thank you, naomba tukae. Please get seated somewhere. Apologies again for some of the delays, from the previous session. My name is Joseph Komwihangiro. I will be your moderator today. So I know today there are many interesting sessions happening at the same time. And I want to take a moment to thank you so much for choosing this particular one. We believe this is going to be a very interesting and a very informative session. The title or the topic for today is focusing on healthcare financing, and we are looking at how we are navigating the new normal, sustaining sexual and reproductive health services in the shifting paradigm. I will make a brief introduction of the topic that we are going to discuss today. And after that brief introduction, I will introduce and welcome the speakers to the podium. And then we will have about 1 hour and 30 minutes of a moderated session, which will involve speakers giving their keynote or their interventions, and also we'll have enough time for questions and answers. To get us started, we know Tanzania has made very significant progress over the past decade in reducing maternal and neonatal deaths. Ensuring universal access to quality care, it remains one of the top government priorities, especially for adolescents and sexual and reproductive health, family planning, post-abortion care, and maternal, newborn, and child health. I've pulled out some statistics from the midterm review of the Health Sector Strategic Plan 5 in 2022, which showed that, external financing contributed to about 23% of the total health sector expenditure in the year 2022. Donor funding accounted for about 63% of sexual and reproductive health spending, and about 91% of that budget, which came from our funders, our donors, was allocated for supporting prevention and the treatment of HIV and AIDS. Government and private sector spending remained very low at about 21% and 15% respectively. In this context of high dependence on donor funding, it may be argued that due to profound challenges in the global development landscape, which is characterized by recent speedy termination of SRI-HR funding by major donors, SRI-HR gains may face threat of slowing down, stagnation, or even reversal, going back from where we came. And this is the new normal that the stakeholders and the champions of SRI-HR are navigating to sustain the prestigious or precious gains which have been made over the past few years. So in today's symposium, which is organized by Pathfinder International, we are looking forward to have this very informative parallel session, which is conducted today in the auspices of the Tanzania Health Summit, bringing together SRI-HR experts and champions, including senior government officials, bilateral and multilateral donors, non-state actors, and advocates. The symposium will offer a platform for a thought-provoking dialogue informed by vast experience, context, enthusiasm to sustain gains. It is also be a new strategic stage, a stage where we can exchange ideas and share experiences, also learn from what non-state actors are doing to maintain the work and sustain the gains they've made in the past. Now I'm going to take the moment to invite the panelists to the table here. I will start by inviting Ms. Gertrude Mapunda. Gertrude, please come to the podium. Gertrude's profile is displayed on the screen here. Gertrude is a very experienced colleague. You know, she works with the British High Commission. She leads the team which deals with human development, and she has been at the forefront, you know, of pushing the SRHR agenda in Tanzania. Second speaker is my friend, Dr. Ahmed Makwani, the Director of Reproductive, Maternal, Newborn and Child Health Services at the Ministry of Health, sorry. Dr. Makwani, karibu sana. Dr. Makwani's profile is displayed here on the screen. I will not read all of it, but he's a gynecologist by training. He's a teacher, he's a mentor, but he's a very good SRHR advocate within the government of Tanzania, and has always been at the forefront of bringing the change and making the advances we have seen. My next speaker, my distinguished guest, Dr. Melissa McNeil Barrett. Dada Melissa, karibu sana. Melissa is the Deputy Country Representative for UNFPA in Tanzania. Her profile is displayed there on the screen. She brings in a lot of experiences from here in Tanzania, but also globally from her role. And Melissa, just to assure you one thing, most of us here have never been in Jamaica, but we love Jamaica. So we love the vibe. So we are very happy to have you here at the discussion today. And last but not least is my friend, Dr. Isiaka Mwandalima, who is the Director of Programs at Pathfinder International. Dr. Isiaka's profile is displayed here on the screen, and is leading Pathfinder's work on SRHR and other programs. So I will also join the panel there. So I will start with you, Dada Melissa. And the reason why I'm starting with you is you are looking at SRHR context from a bird eye view, you know, from the global stage, you know, given UNFPA's mandate globally and in Tanzania. So probably you may be able to bring in the international perspective, but at the same time looking at how it is reflecting with the change in Tanzania. So I know that accelerating SRHR gains, you know, is one of your core areas of focus. I also know that, you know, things have not been very easy in the last few years at the global stage there. So apart from geopolitics, what are the other key influencers, you know, which is influencing what we are seeing now?
Habari za asubuhi, and thank you very much, Chair. I think you've raised a very important point. As we know, the geopolitical situation has really, you know, sort of presented significant challenges to the sexual and reproductive health and rights agenda, which has always been a very sensitive agenda, but even more so recently, we've seen a shift, particularly in terms of further pushback against the agenda. There's a lot of pullback on some of the progress that has been made. We've seen it through the politics, the political situation, but there's also issues around economics. So we've seen where countries that are facing economic challenges have shifted financing and funding from the health and social sector into other areas that are considered you know, more harder priorities. So we've seen a shift away from social sector and a shift away from funding towards sexual and reproductive health across several countries. We've seen as well there's an escalation in terms of humanitarian crises, right? And so we all are familiar with the Ukraine situation, with Gaza, Syria. And so we've seen a lot of our donors who were quite supportive or who have been supportive of the sexual and reproductive health agenda having to shift or taking a decision to shift resources increasingly into the humanitarian agenda. And so funding has gone into that area and has been reprioritized across several of our countries. We've seen as well the issue of climate change, right, and environmental issues. We've seen situations of flooding, and this has also impacted how funding has been allocated where sexual and reproductive health and rights are concerned. Unfortunately, and I think we'll get into that into the discussion, when you have these sorts of crises, whether economic, whether environmental, whether humanitarian, it is often your social sectors that suffer, right? And already we know in many countries, the budget and the allocation towards your health sector, in many cases, is usually even below. In the case of Africa, for example, there's the Abuja Declaration, which countries have committed to at least 15% of the health sector budget, of the budget being allocated to health sector. And in many countries, we've seen that that allocation is below the commitment. And so when there are crises, the funding towards health suffers even more. And so this is some of the things that we've been seeing across the globe, which have affected SRHR and the funding to SRHR across countries. And we're seeing it as well in Tanzania, not least of which we've seen this year in particular a significant reduction in funding from key donors towards the health sector, which certainly has had an impact on sexual and reproductive health, and in particular the family planning agenda, and we see it very much clearly here in Tanzania. So very broadly, those are some of the main issues. One other one I should mention is it's health emergencies and pandemics, right? So we've seen, as well we know, just in the recent past, we had COVID, we had, Marburg, other issues which we see again when we have those health emergencies, when there are pandemics, the funding shifts a bit into some of these areas. And therefore, these are some of the aspects that affect funding being channeled to sexual and reproductive health and rights.
Thank you. Thank you so much, Melissa. So the word funding cut, I was trying to count how many times you mentioned the word funding cut, was one of the most used word, in your discussion. So maybe from your experience, do you feel that this is a temporary situation, or it is the beginning of the new normal that we should be setting to navigate?
That's an interesting one. I think it's the beginning of the new normal because, we've seen the trend, and I think we won't necessarily see a reversal of that trend because increasingly there's a lot of, especially across countries that have typically funding, there's a shift towards other issue areas, as I mentioned, which means that I think at country level there's a lot more emphasis and requirement on countries to already take this issue, this matter into their own hands. And so I think it brings us into another point where now more than ever domestic resources are required towards sexual and reproductive health. And so in the case of Tanzania, for example, we know that in many cases the sexual and reproductive health, and particularly the family planning agenda, has been in the past very much funded externally by development partners, but we want to commend the government. We've seen this year, I think, partially precipitated by the funding gap, but also government leadership on putting additional resources. We've seen it coming through in the budget, and we've seen the increasing commitment to resources around family planning, but there is more that is required because it really requires now countries and governments to put their own financing and resources towards family planning to offset these cuts. And I've been talking about the cuts, but the cuts, the reason why the cuts are critical is because they're affecting the lives of women and young people. So when we have these funding cuts and these gaps, it means that women are not able to access sexual and reproductive health information and services, whether it's family planning, whether it's maternal health services, which has implications for their lives, right? So you can't plan and space the number of children you have. Young people are not able to access family planning to prevent unintended pregnancies. Women may have difficulty accessing maternal health life-saving services. So at the center of these cuts is the fact that people's lives are being affected. So it is even broader than just funding cuts. It is how we're impacting the lives of women and young people and the population at large.
Yeah. So it is the beginning of the new normal.
It's the beginning
so
of the
Dr.
new normal.
Makwani, in the beginning of the new normal, we all celebrate the big achievements that have been realized by Tanzania as a country, in the last decade, especially in the area of SRHR. We have doubled, more than tripled the number of CMONC facilities. We have seen a significant reduction in the under 5 mortality. We actually achieved our Millennium Development Goals for under 5 mortality. We have recently seen more than 80% reduction in the maternal mortality, you know. Now, in this changing paradigm, you know, in the new normal that our colleague has just explained, how is the government handling this? How is the government preparing or planning to handle this to make sure that these beautiful gains we have gained over the past 10 years are not lost? Thank you.
First and foremost, I think it is important to note that I don't think if we were prepared with these changes, and when they came, somehow we had a time of a kind of shock. What are we going to do? And then we passed that stage of accepting the truth and starting to address the truth. And for the government, it had many issues to deal with. First of all, you understand the funding that was flowing in country was not only procuring those commodities we are talking here. It was hiring some of the Tanzanians. And you can imagine if one Tanzanian is hired, how many family members will be depending in that a single Tanzanian. So the most shocking question was what would happen to these people who have lost the jobs? And we are not talking of hundreds, we are talking thousands of them. So that was an area, until today I would say the government is looking at it to see what can do to those people who have been out of job due to these changes. Coming back to your topic, first of all, there was issues with the commodities. And here we are talking family planning commodities, commodities for women who are pregnant and delivered as well. We are talking about ARVs and a bigger spectrum of commodities. How do you accommodate with that kind of all of a sudden? You look at the numbers, you find a lot of gaps. You are told after 3 months, if we are not funding this area, maybe we will not have family planning. After certain months, if we are not reacting with these changes, we won't have oxytocin, and etc., etc. So you are seated in the office and you find yourself in a situation that we are going into a ditch. Fortunately, after the government responding, we saw some of the responses, of which I think not only shocked us as implementers, but even new partners were shocked to see how the government has responded. The response, of course, was very significant regarding to our economy, very, very significant. And the government was committed saying that no woman shall miss family planning if she needs. No woman shall not die if needs oxytocin, and etc., etc. ARV, if we are not going to afford to have shortages. And we saw the challenges. But as part of the implementer, I also saw some of the efforts which are taking place from within the sector, but outside the sector. We had several meetings, by the way. Some of them were lasting very late at night to discuss how we can cope with various challenges. And it went high up to the head of state. And I'm told those people who went there, they were asked, how much do you need? So that we can offset the situation. And we saw the money is flowing, significant amount of funds. And these were not just promises. You see the check is already at the medical stores department. So I look at it, it is a shock, a big shock to see all of a sudden you were relying this consignment, and then all of a sudden you see that consignment is not coming. But it is also, I see, an opportunity to learn that we need to get prepared of those shortages, because you can't rely every day with someone who is giving you. So we need to get prepared for it. Yeah. And I would say the best we can say, let us live with this reality now so that we can move forward very smoothly, than denying ourselves, saying that maybe someone will be coming to rescue us.
So, Dr. Makwani, you know, your department in the ministry, you know, covers a lot of things, and you know, the government, of course, is responsible for everything, but there are components which tend to miss the attention, you know. Issues around GBV, issues around post-abortion care, issues around, you know, family planning, and so I just want to hear your sense. Are you worried that there are areas where you think we will go backwards and lose the gains?
Possibly, I would say I don't think if there is an area which is missing the attention. As you have mentioned, the post-abortion care, that's why we do have guidelines. As you mentioned about GBV, that's why we have the guidelines. I would say all these are operational, all these are being implemented. And the best I could say is I feel happy the way the government has handled our situation. Because I know my colleagues from nearby countries, until now, some of them have not settled. They are moving in a very dire situation in terms of ensuring service delivery remains to be the same. Here, it is extremely difficult for a common man out there to say there was somebody who has withdrawn and we have some shortages of some of the commodities. We see the services are being run, although at a government level we see we have...
One more follow-up question for you, Dr. Makwani. You know, the government of Tanzania, the Ministry of Health and the other ministries have demonstrated very good partnership with non-state actors, you know, and some of us who are coming from the non-state, from the non-government organizations, we also cherish and celebrate the results and the gains which are seen in the country, because we know also that we have contributed. In recent months or recent years, I would say we are seeing a trend where the donors who used to fund NGOs are increasingly coming to the government, are increasingly negotiating with the government rather than negotiating with us. And to me, that raises a worry that the equilibrium is shifting, because we have always maintained a very good equilibrium between work done by non-state actors and work done by the state. So from your point of view, what are you doing as a head of department, but also as a senior official, to make sure that you restore that equilibrium?
The change of equilibrium, I think, Tanzania is not the one who is starting it. We have seen it, even the first world now, that state ownership is increasing, even the first world. And I would say, yes, there is a shift to inclining toward the government in terms of providing resources for various implementations. I would put it this way. Most of these funders, they want quick results.